move on and welcome back Rob Elliott-Cook, who has spoken on these masterclasses before in another guise when he used to work at Royal Free, now leading clinical pharmacy in this Royal Devon and Exeter, and is going to talk to us about some of the challenges of going live with EPMA during a COVID pandemic. We'll then talk about what's coming next and opportunities that are coming up. If you have any questions, it would be great if you could put them in the questions bar, please, as we go, and we'll pick them up at the end of each of the two presentations. The slides will be shared at the end of the presentation through NHS Futures, and Sarah will be emailing and contacting people out, and the session is being recorded as well and can be accessed. So again, if you have any particular topics or anything else that you'd like to see, if you'd like to become a star of the ePrescribing masterclasses, then please do get in touch, and the details are on the screen for Sarah from the Northeast AHSN. So without further ado, I'm going to hand across to Andrew, who has been doing a sterling work of moving all the work that we've done on information and interoperability standards for medicine into a formal information standards notice. Andrew, over to you.
Lovely, thanks for that introduction, Anne. That's very kind of you. So a very, very brief introduction to me. Currently, I work at NHS Digital. I've been here for 7 years as sometimes as a project manager and sometimes as a benefits manager. I've worked across a range of programs, but the main ones that I've predominantly worked on are the electronic prescription service, which is in use in GP and community pharmacy, the interoperable medicine standards, which is relates to what I'm going to tell you about today. And also on a collection at the beginning of the COVID epidemic from hospital EPMA systems. Sorry, that's my phone ringing, it's typical, isn't it? Just get rid of that. A collection of medication and administration data from hospital EPMA systems to support COVID work and responses. So if I can have the next slide, please. So an information standards notice. NHS Digital has a process where these are produced, and it is essentially to require something to take place in the NHS. They usually are levied on hospitals. So if you look on the digital standards page, you'll find most of them relate to acquiring generally data from hospitals, and that data is to support things like the radiotherapy data set, or maybe to enable publishing of the referral to treatment waiting times, or maybe to support collection of data for the emergency care data set. This information standards notice was commissioned by NHSX and has been put in place so that when we transfer patients' medication and allergy or intolerance information, we can move that between NHS locations in a format which makes it machine readable and computable, and it then enables interoperability, and it means that the data can be integrated on receipt. So it's not about collecting data. This standard isn't put in place to collect data. It's about reducing the effort that we need to make it usable as it moves around the NHS. Next slide, please. Okay, so there are three important timescales sitting around this information standard notice. The first is that we received formal approval from NHS Digital's Data Alliance Partnership Board to publish the standard. So that was given in September, and on the 1st of October we went live on our website with the information standard and with the supporting documentation for that. The standard it applies to users, so for example hospital trusts, GPs, those working in ambulance trusts, and there's a requirement for them to look at the standard, assess where they've got existing electronic medication transfers, and identify whether those transfers are compliant with the terms of the standard, and if not, work out how they need to comply, and they have 18 months to look at those existing messages and work out if any changes are required for compliance. We have launched a communications package to support the publication of the Information Standards Notice. So you may have seen some information about that already in bulletins, and the communications will continue over the course of the next 18 months, and we are of course also working more directly with system suppliers as well, to inform them about the standard and help them work out how to implement certain aspects of it. Next slide please. So the full conformance date for the standard is the 31st of March 2023. So at that point, if there's an electronic transfer within the NHS of medication and allergy or intolerance, then that will need to comply with this information standard. And I'm going to go on in a couple of slides to give a bit more information about what's contained within this. Obviously, if you don't have a system in place that's doing an electronic transfer of this information at the 31st of March 2023, it doesn't mean that you have to have a system in place. You have to discard your current system and then go and get an electronic one. We appreciate that this standard is all about improving the process that's there electronically already. It's not about forcing everybody to instantly change over to an electronic system on the 31st of March 2023. I'll come back to that point a little bit later on as well. So if we can move to the next slide, please. What I want to talk about here is a little bit about what contributes towards the standard and a little bit about the way it works. So if you look at the diagram that's on the left of the slide, you'll see in the first column that we've got essentially 4 key elements that contribute to the standard's contents. So what we want to do is ensure that the Dictionary of Medicines and Devices codes are used to uniquely identify medicines within a message, and also if that's how they've been coded in the native system, allergies and intolerances will also be identified with a DM&D code. We want to use the SNOMED CT terminology system to code dosage, and also it's commonly used to code allergy and intolerance across a wide range of systems. So we want to ensure that we use SNOMED to enable that machine readability of dosage instructions as they move around. And then this is wrapped up in a messaging standard which is called FHIR, and that's the Fast Healthcare Interoperability Resource, and that is essentially a message that defines how the content for a specific purpose is moved around the NHS. So I've got some examples that show you how different parts of FHIR can be used for different purposes. So we're going to hit those in a couple of slides time from now. And then the other key thing to be aware of is that we've worked with quite a lot of organisations to develop this standard. Mainly we've worked with the Professional Record Standards body, who look after the developing guidance for electronic medical records, but we've also worked with people like the development team for the UK version of FHIR, and we've worked with Interopen, which is an organisation that works very closely with lots of NHS system supplier developers, which means that we've taken into account a lot of perspectives as we've developed the standard. The overall aim is if you move to the second column on the image, that we gather together all of these sources of information and ideas and ways of developing the process, and we use those to develop a specification for a particular use case. Users will then contract with their system suppliers to make sure that their system is going to excuse me, is going to support the Information Standards Notice. Oh, I'm just going to have to stop to get a drink. Sorry about that. I've got this cold that's flying around everywhere at the moment and it's impacting on my voice a bit. Once users have contacted their system suppliers to work out what changes can be made and how the system suppliers intend to approach that, our expectation is that the system suppliers will develop, using our specifications, an API that does the sending and receiving of this medication and allergy intolerance information. That's then made part of the system so that users essentially go about their normal working day-to-day tasks pretty close to what they do now, but that information is transferred using the API, and it's transferred using the standards, which mean it's interoperable, and there's no stoppage of that information as it moves around the NHS. Okay, if we can have the next slide, please. So here we're looking at the scope for the standard, and it is simply all of the organisations that are funded by the NHS or sit in social care and are funded by the NHS. The exclusions are health and justice, so that's locations like prisons, police custody suites, juvenile detention centres, and private care. So, for example, your private hospital, which is completely separate to the NHS. There's some overlap, obviously, where a private hospital might be treating NHS patients under a contract. And we need to tease out exactly how we're going to look at information flowing when that scenario occurs. But there are changes going through legislation at the moment, which will probably support us with that. I mentioned earlier that there isn't a big bang type approach of if you've got a paper system at the 31st of March 2023 that you would suddenly be expected to change to a computer system. But if you do have a computer system at March 2023, there is an expectation that that will be compliant at the end of March. However, it doesn't mean that things can't develop more quickly than that. So, for example, we've worked with Careflow Medicines Management, which is what was previously known as WellSky and before that JAC, and also with Daedalus, which you may know as Lorenzo, to develop electronic ordering between wards and inpatient pharmacy. And we've got a wider deployment of that process planned before the end of this year. We're about to start testing electronic prescriptions from hospital outpatients to community pharmacy, and that's work which is sitting alongside the overall upgrade of the electronic prescription system, which is currently operating in general practice and in community pharmacy. Okay, so let's move on to the next slide, please. Just a tiny bit of background about FHIR, because this is helpful as it relates to the examples that I'm going to move on to in the next 4 slides. So FHIR is an international language, but the UK has decided to produce a UK version which is adapted for our very specific needs. That's currently referred to, the version that's in use widely at the moment is known as Care Connect, and that is version S2U3. That's a standard for trial use. And we're quickly moving towards a newer version which is known as UK Core, but also known as Release 4 of FHIR. So the specifications that we've developed so far are available in both versions, so developers, we would encourage them to use the newest version, but there isn't a limitation that stops them from using an older version. And there are 4 resources that sit within FHIR which we've focused on over the last couple of years and done a lot of development work on, and done a lot of development work with system suppliers and users of the data as well. We've got medication request, which essentially allows you to order a medicine. We've got medication dispense, which is an outcome message about what happened as a result of your order. Medication statement, which allows you to give information about medicines. So you might be informing what patients the medicines had in the past. You might also be informing what medicines they're taking now, and potentially even what they could be taking in the future. So for example, if a patient's discharged and you need to inform that a course of medicine needs to start in 5 days from now, that's how you would describe a future medication. And then we have medication administration, which is used to record the actual giving of the medicine to the patient. And whether that's by a caregiver or by the patient themselves, it can still be used to capture that, whatever whoever the administrator is. So if we can have the next slide, please, and then I've got 4 examples that I'm going to talk through. So this is one that I mentioned already. This is the process of a hospital ward being able to order medicines electronically down to their inpatient pharmacy. What we have here is a patient Violetta, and her consultant, Mr. Sorella, decides to prescribe amoxicillin. So that's requested on the ward, and there's a pharmacist review. And then Ishani then sends this order from the hospital EPMA system using a FHIR message and using medication request in particular, because that's the FHIR message that we use for an order, and that transfers across to the inpatient pharmacy system. On receipt, because the message has got, it's used the DMND code for amoxicillin, and it's used SNOMED coding for the dosage of 3 times daily. The pharmacy system is then able to read that electronic information, and there's no need for that information to be typed in the pharmacy. And the pharmacy system can then offer to the pharmacist, this is what I think you want to issue for this patient, and then it's able to be modified if necessary, or in most cases what we're finding is that what the pharmacy system then offers, drawing from the message, is correct and doesn't need any manual changes. Once that's happened, the pharmacy system can then return a FHIR message using medication dispense, which can go back to the EPMA system and would typically inform that yes, that medicine's been dispensed and is now on its way. It's on its way to being delivered to the ward. So at the bottom, you can see that in December 2020, we went live with this process in the University Hospitals of Derby and Burton. It's using the slightly older version of FHIR, so it's using the Care Connect STU3 version. It's using APIs, which were developed using the specifications that we produced, and it's working extremely well. What we've seen is a reduction of manual transcription of orders approaching 94%, which is a phenomenal change in workload, phenomenal workload reduction. There is a detailed lessons learned report available, which is intended for hospital trusts who are thinking about implementing this process, and also for developers who are thinking about making this product available to their users. That's available if you'd like to email medicinestandards@nhs.net and ask for a copy of the Derby Lessons Learned report. Okay, let's have the next slide, please. So another example where this information standard applies is for discharge of patients and the information that flows when that happens. So here we can see that Rania has been discharged with a supply of metformin. Again, we have a pharmacist review. That results in a FHIR message being created using medication statement, which is the informer type message, and that can then be transferred to Rania's GP, asking the GP to take on the supply of the metformin 500 milligram tablets twice daily. Again, because the GP system will in time be built to receive these messages using the specifications that we've developed and using FHIR. The same type of benefits apply there, that the information can be ingested, it's machine readable. There isn't a requirement for the GP to sit in their practice, look at this on screen and then have to retype it into their system, so it then becomes a prescribable medicine within their system. And to support this type of process, we've been working with the Wessex One medication record platform to essentially upgrade their existing messaging process, which isn't FHIR, and we're looking to uplift that to the newest version of FHIR. We're also working with the Somerset Digital Medicines project, which is developing a shared medication record using FHIR, and they have hospital discharge as a high priority use case within their portfolio of products that they want to develop. If I can have the next slide, please. This is the third example of the four. And this one looks at how we might communicate with a shared medication record. And these are being developed by integrated care systems across the country. So what we have here is our patient Wachter, his consultant Mr. Stroller decides to prescribe goserelin. And for that to be given by an injection in an outpatient department this afternoon. So Mr. Stroller is able to use the EPMA system to transfer that order down to pharmacy. It goes in a FHIR message and pharmacy receives that, and the pharmacy system is able to process it pretty much automatically, because that's got machine coded data in there. We're using DMD and we're using SNOMED. The process applies the same as before, that there's a dispensing message that goes back to the EPMA system to confirm that order's been fulfilled and it's on its way, it's being delivered. And then the EPMA system, on receipt of that, potentially can send a message out to the shared record, which is accessible across the NHS patch, to say that this medication is being prescribed for Wachter. And then we can imagine that Wachter comes in for his outpatient appointment in the afternoon and his nurse administers that medicine, at which point that's recorded on the EPMA system, and a FHIR message is generated, again sent out to the shared record using medication administration, to inform the shared record that Water's had this injection administered. So this is sort of a very much a summary view of how we might communicate with a shared record, meaning that the shared record is pretty much always up to date, so that if a different hospital or perhaps a GP or somebody out in the community queries the shared record, then they've got that information to hand and it's accessible, and again it's codable and shareable. And then if we can move on to the next slide, please, to look at the final example. What we can see here is looking at the electronic prescription service, next generation as it's being called. So this is a development of the original electronic prescription service, so that it's easier to upgrade and it's easier to deploy into other areas of the NHS. Here we have a patient, Svetlana, who attends her GP and is prescribed some cocodamol. Her GP issues an electronic prescription, and that's sent using a FHIR message to her nominated pharmacy. And nominated pharmacy means it's one that Svetlana has decided she's going to use as her regular dispensary. That pharmacy then downloads the message from the spine, because again it's using DMD to identify the medicine and it's using SNOMED to code the dosage, the pharmacy system is able to accept that message and present it for labelling without the need for any alteration or transcription by the pharmacist. And then again we can have a medication dispense message that's going back to the GP to inform the GP that medication has been dispensed now. Supporting that work, the Interoperable Medicine Standards Programme has been working with the Midlands Partnership Trust to look at issuing electronic prescriptions in outpatients, and those can then go on to be dispensed in community pharmacies. We're using the newest version of FHIR for that, and again we have a specification that's been written which the different system suppliers are using to develop their APIs and their products. In time, we have a roadmap where once we have that operational in outpatient prescribing, we'll look at whether we can provide the same process for home care. And certainly if you're in a hospital setting, you'll know that home care is a significant administrative burden at the moment. So we're hoping we can reduce some burden and improve some, add some efficiency and safety into that process, certainly for hospitals and home care providers. Okay, so if we can move to the next slide, please. Very quickly on this one, because I can see I'm running quite close to time. As you'll have gathered, at the moment there's certainly two versions of FHIR in use. We've got the Care Connect STU3 and the UK Core R4. And we recognise that there's a potential for development by suppliers to be stifled if, for example, in the Leeds Hospital Trust, they build their products, or their system supplier builds their products to use Release 4, but actually out in GP land, they're still sitting with STU3 Care Connect versions of FHIR. So what we are building is a process called a FHIR transform, which will be able to convert between different versions of FHIR messages, so those that are around now plus those that are developed in the future. So we're well on with this piece of work, and hopefully that'll remove any potential restrictions to the development of interoperability for FHIR messages. Okay, next slide, please. The final thing I want to do is to look at some of the outcomes and benefits that we're delivering by this process. So for hospital prescribers, what we're going to be providing is basically a system where there's a much reduced need to type information in when patients are admitted, or maybe when they move between different specialities in a hospital, and because that information can move around EPMA systems and in and out from GP systems electronically. For pharmacy professionals, as you've heard already, for inpatient hospital pharmacy, and we've got a process that's working now and is going to be deployed more widely before the end of this year to allow electronic ordering from wards. For GPs, as you've seen from our examples, we're looking at hospitals being able to provide the discharge information electronically in a machine readable format. It's available in a lot of locations now electronically, but it's not available in that machine readable format. So what we're looking to do is to get that uplifted so that we don't need to have somebody sitting in the GP practice retyping things and potentially maybe making an error that changes the original intent of the supply. And for patients, we hope that what we can provide is less time for them having to tell hospitals and GPs and others what medicines they're on, and whether they have any allergies, intolerances, and just for that information to flow around the whole NHS ecosystem in a much improved way. And the final slide, please, is just to say, the slide set's coming out, so you'll have the links to get to the Information Standard Notices webpage. That's got a document on it called a requirements specification, which gives real detail about what's expected from whom. And if you have any questions, the Interoperable Medicine Standards team will be very happy to answer those if you'd like to email them through to medicinestandards@nhs.net. And as I said, if you're interested in picking up the lessons learned report from the Derby implementation, if you email Medicine Standards, then they will be happy to send that out to you. Okay, that's it for me. Thank you very much.
Thanks, Andrew. That's incredibly helpful. So I think in summary, there's now an information standards notice which the NHS trusts and other providers of services will need to comply with by March 2023 it's an opportunity for all those working with systems to work with their system suppliers now to ensure that they do the work necessary to get this in place, such that they'll be able to benefit. Standard NHS contracts will have in them so that suppliers should conform or must conform with NHS standards. This is an NHS standard now, so it gives you the opportunity to start to pick up and work with suppliers over the next 18 months to ensure that they are able to support this. So a couple of questions, Andrew. I'm not sure whether you'll be able to answer the first one.
Okay.
A question about an issue with the ordering of meds where they have multiple possible routes of administration. Has that been resolved?
We're working towards it, but we'll never get 100% because there's such a variance in the system. The work in Derby has been quite helpful because we've identified a lot of those edge cases, I guess, and we've worked to try and put some solutions in place. There's a bit more information about that in the lessons learned report.
And the reality is the information can still go across, can't it? It's just that when it gets to the
sorry, that's true. Yeah, it can still transfer electronically, but you might need a bit of manual intervention. So you're no worse off than you were before, really.
Well, I'd argue you're better off actually, because you're not having to rekey patient data and other stuff as well. So we thought it was going to be the 80-20 rule, didn't we, Andrew? But it's actually 95-5. We've actually, 90% translatable without intervention, which is fantastic. So
yeah, that's right.
Okay, there's a question. Okay, what if the hospital discharge prescription is in dose-based format? Does this translation to product-based format happen automatically, or is a manual step required?
We are working very hard on that, and our expectation is that, again, for the majority of medicines, we'll be able to do that automatically. We're putting in place processes with GP systems so that there's improved work there to code dosage and things. So yes, it's high on our agenda, and we're working very hard to get as best we can on that. Won't be 100% again, but we think we can get a good percentage achievement rate for that.
Next one is an interesting one, and I guess it's one of the real conundrums working in this space. Is the full conformance, is the date of 31st of March 23 achievable for full conformance, given the wide variety of trust systems that are out there, the variations? Some suppliers have got long roadmaps and so on, and may not be able to invest in change to bring this in place.
Yeah, we've certainly kept open lines of communication with suppliers, and I think at the moment, 2023, we've been led by the pace of change for GP system suppliers, who will need to adapt this as well, of course, and to implement the dose syntax work. It might be challenging for some suppliers, but we have had a lot of behind-the-scenes dialogue. Our belief is that all the major suppliers knew about this in advance and had got opportunities to interact with us and potentially push back if they thought it was going to be too difficult.
I think it's one of those age-old conundrums, isn't it? If you don't set a date, then nobody takes it seriously. If you do set a date, then the devil, some will meet it, some inevitably may well not, but at least we're all pushing towards conformance at a certain time. There is a lot, as you say, Andrew, there's been a huge amount of work behind the scenes to make sure that suppliers are on board. And this is an international standard that we're using. So we've tried to make sure that we align as much as possible to work that's going on internationally, so that those system suppliers working across the world will be seeing the same sort of things happening. And indeed, we've learned lessons from some of those wider implementations. Question, do unlicensed medicines cause an issue? No, if they're in DM&D, there should be absolutely no difference whatsoever. If they're not in DM&D, that is more of a challenge. But there is nothing to stop free text information going across. Again, it's a structure within which the information can be unstructured. There are certain fields that could be used for non-coded medicines if need be. And then, did you say at a previous meeting that EMIS will move to fire as they're currently refusing to entertain our request to link EPMA to dispensing? So EMIS have been working on fire, I believe, Andrew, haven't they, EPMA to stock control?
Yeah, we were hoping to work with them in the summer, but they needed to change their roadmap around to for another high priority piece of work. So the last I heard, they were going to pick up back with us in January of 2022. So again, we've had close working relationship with them and good conversations with them. So they do know what we are hoping they will achieve from this.
And again, behind the scenes, lots of conversations on with them, because clearly with this now being the standard, this is the route that that they're going to have to take moving forward. So we will be picking up with them. And please, you know, Nikki, keep up the pressure. This gives you the lever that you need to keep pushing to make sure that they do the work that you need them to do. And I'm sure they'll be happy. You know, they are communicating. They have looked at all the information and they have got the information. It's just a question of pressures around priorities for delivery. Question from Edwin: will there be real-time feedback to hospital staff if medication prescribed in hospital can't be taken on by general practice, for example, unlicensed medicines?
I hope so, but one of the ways we approach our specifications is we'll inform what the minimum viable product is. So it might be the case that the message that comes back from a GP only has to say that they've received the message, or it could be that when we develop the specification for that, then we can put a minimum viable product in of having much more information than that. We've got an interoperable medicine standards working group which helps evolve these specifications and ask these questions. So very happy if you want to email the medicine standards at nhs.net address with that, and then we can factor that in as we get a bit further on with the development and the building of the specification.
I think the reality is that actually these standards provide an awful lot of opportunities, and in some respects, you know, we don't actually know what many of them are going to be at the moment. There's all sorts of things that do keep cropping up. And indeed, the hackathon that's being run next week, we've got a new tool which is being pulled together by FDBE using these standards to provide cumulative dose checking on administration. We've got somebody coming along using these standards to support translation of dosing information into different languages. We've had somebody looking at creating information to support pediatric decision support and dosing. So actually this is opening up a world of opportunities, many of which I don't think we fully understand yet. And Andrew, I think it's fair to say they're still coming out of the woodwork, aren't they?
Yeah, definitely, yeah.
Okay, I'm going to stop at that point. Thank you, Andrew, and we'll move on to Rob. And Rob, apologies, we're squeezing the time a little bit for your presentation. Rob has been incredibly helpful. In fact, was right at the beginning of the journey with the wider group in terms of the EPMA to stock control and helping to define the workflows, and that was the basis upon which we then built all the standards. So welcome back, Rob, and great to hear that you've been a little busy over the last few months. So over to you.
Thanks, Anne. Yeah, and thanks for the previous presentation. That was really interesting. I suppose a sort of slight contrast, a bit more a sort of what's happened during the last year. So I'm Rob Elliott-Cook. I'm the clinical pharmacy manager at the Royal Devon and Exeter Hospital. And I'm here really just to talk through what happened a year ago. So I know I'll try and keep all of the sort of COVID information to a minimum and talk specifically about our experience of EPR Go Live, but just to say it was an extremely different one. So this was actually now my sixth sort of cutover experience. So I've done 6 EPMA Go Lives in my career. So I'd like to refer to myself as an EPMA enthusiast as well as a clinical pharmacy manager. And this specific Go Live was with the Epic install. So who am I talking to? Sarah, are you helping me with slides? Thank you, Sarah. Can I have the next slide, please? So here's a little poster. So this is some of the some of the comms that went out. So it was originally planned for June 2020, and complications associated with the pandemic, as well as a few other small setbacks, meant that we ended up going live in October 2020. Next slide, please. So it was with Epic, and it included inpatient, outpatient, ambulatory, community hospitals, community services, a patient portal, and integrated pharmacy inventory. So there was small exclusion criteria, which included CRIS, so that's the radiology system, and chemocare, of which we are both included in our future plan to move across later. So it was October 2020, so I know that a lot of you want to forget that period of time, and it was a very difficult period of time for the NHS, but we really built it in as part of our recovery programme. So following the first wave, as you'll be aware, the Southwest didn't experience anywhere near the numbers that the Southeast did in terms of COVID inpatients, but it was a really hectic time given the fragility of the NHS service down in the Southwest, given that we would reach capacity much sooner than other parts of the country. So we saw it as an opportunity, really, given that we put in all the hard work to build an excellent system, to then move forward with the go live and see it as part of the COVID recovery and ensure that we could better and more safely care for patients with an electronic patient record. Next slide, please. Oh, was there one between that, Sarah? No, it's disappeared. Okay, we'll move on then. Okay, so there was just another slide in the middle there that I thought must have disappeared on transfer, but just about the amount of staff that would usually be involved in a go live was significantly reduced. So we had a really huge amount of support, but a lot of it was remote, and as you will all see from me working from home, I've never worked from home in my career before, but I'm here, and so are many of you, and we had to sort of adjust that according to what we thought would work best, try and reduce the footfall within the hospital, but where required, we did bring people in. So it was a paper to electronic cut over go live, and so it still required people to physically be in and looking at charts, as well as the clinical teams who would regularly be looking after the patients. Okay, so so less face-to-face support. So what we did to sort of try and adjust to that was we actually employed additional staff. So where we would have usually spent a short, sharp amount of money around that cut over and initial support period, we actually brought in some more temporary sort of fixed term contract staff for a 3 to 6 month period, instead of bringing in those temporary staff and increasing a huge amount of staffing throughput that you will have been, that some of you will be familiar with. Let's just get rid of that screen. Okay, so let's just read through a few of the points that I've raised here, and I'm just trying to keep an eye on the time as well. We rapidly adjusted our training schedule and moved completely to an online delivery with a few sort of classroom opportunities, but what we did was sort of peer-to-peer training schedule as well. So you would have a particular individual within the department or within a specialty who would then spend time with their colleagues, showing them the play environment of the system to get them familiar before go live, rather than that sort of extensive face-to-face training that you might have seen in previous EPMA go lives. We and probably many of the future EPMA go lives will be moving to almost complete online delivery. I said about the floor walkers. One of the things that was good was that we actually had a really good staff retention for technical support teams. So our analysts and everyone who was moved into the sort of technical side of the go live. We saw a lower throughput of those staff until those pandemic restrictions were lifted, and then like some of the people on this call, they've disappeared to other organizations, but you know, all the usual stuff. It was a really good experience after we went live. In context of experiencing the first wave of the pandemic, it was so much better as we had an increased number of COVID patients later on after we'd gone live. It was a lot easier for clinical staff to be involved in the care of COVID patients and other patients, given all the restrictions, and it really supported all of those moves to virtual clinics and things like that. Next slide, please. So I know that a lot of people on the call will be from a sort of pharmacy background as well as other EPMA things. So I wanted to just briefly talk about the pharmacy specific experience and in context of the previous presentation. So Epic is a fully integrated system with pharmacy inventory. So most of the newer clients with Epic have taken on the integrated version. I think you heard from Pritesh at Great Ormond Street previously, and given their huge input from UCLH and Great Ormond Street, as well as the more historic input from Cambridge at Addenbrooke's, we actually had quite a good experience for our pharmacy go live. It's a huge effort getting all of those things right, which has been reflected in the previous presentation of linking a prescription to a product. There's a lot of work. So within pharmacy itself, we employed some additional sort of band 2-3 staff who helped us with sort of counting and building our stock inventory in advance of go live, and this was just invaluable to get everything right, ready, so that as soon as we moved over, it was all there. Yeah, just to add into the mix, we were one of the last trusts in the country, I think, to get a robot installed in our dispensary, and that happened not long before we actually went live with our Epic system, which again required a lot of effort and support. Okay, next slide, please. So overall, we think it went pretty well. I think there was a lot of people who sort of pulled together following that initial sort of the initial wave of the pandemic. I think everyone was apprehensive about moving across to an electronic system and all the effort that would be required. But since we've gone live, we've had really good feedback around moving from multiple electronic systems and paper across to a single EPR, except for those exceptions I mentioned earlier. Much better support for virtual clinics, as well as better support for virtual prescribing. So we've done a lot of work with Boots, who provide our outpatient pharmacy, and our home care providers to try and establish a better relationship of transfer of information. And that's really supported the move to a lot of these COVID changes that we've undergone, as well as our community services. So they have better links into our acute trusts now, and are able to review and care for those patients better than we were before. A lot of it's more transparent now, so you can see things that are occurring better than we used to be able to. We wouldn't have been able to do this without the support of other organisations who'd done it before. And I think not only did they supply us with staff from their organisations to assist that initial 2 to 4 weeks, but they also supplied us with and provided us with a lot of historic information about how the system worked, and the sort of things to look out for and how to cope with that operationally and organisationally, as well as the sort of the build, etc. We had some really good feedback from those super users that helped us during go live, as well as from our patient population. So we introduced a patient portal as well. and we almost sort of gave back the data that the own, and received incredibly good feedback during the initial period and continue to do so. I've put a hyperlink down there from a colleague at UCLH, David Kuo, who's has written his experience of the Royal Devon and Exeter Go Live to give a slightly sort of more external perspective on how things went. Next slide, please. So we're only one. Just move that out of the way. Oh, weird. The question thing keeps popping in front of the slides. So 1 year on, so we're 1 year into using our EPR. I've put that we're also thinking of then expanding this into other organisations within Devon. So our CCG, or whatever the future of that is, will be is a sort of Devon-wide clinical commissioning group, and the scope of our sort of the wider expansion of some of these electronic prescribing programs includes North Devon and potentially Torbay in the future. So briefly, yeah, I mean, it was a big bang go live. I know that some of you will have experienced various different phased or big bang things. I think in the middle of a pandemic, we had to go all in, or I think it would have been a struggle had we seen an uptick in the number of COVID inpatients. At the time of going live, we were down to some of our lowest levels of COVID inpatients, and I think that's partly why it was possible. There was really good executive and clinical support for this go live to support particularly some of our more specialist outpatient services, as well as looking after inpatients better. And I think, yeah, if you want any more recommendations or information, I think probably looking at the time, I should give it back to Anne if there's any questions, but do feel free to get in touch if you want any more info. Thanks.
Wow, I can't believe it's a year, Rob, since that you went live. I remember talking to you over the autumn last year about vaccine rollout and so on, and I know that you were running around at that point in time, but crikey, a year, that's incredible, isn't it? How are people feeling about it? Would they give it back, or are they still wanting to use it?
Yeah, I mean, I don't always get I think sometimes it's sort of no feedback is good feedback, but we did a sort of year in, I think a couple of weeks ago, 2 or 3 weeks ago, and tried to get a lot of feedback back from the end users. And again, it's there's sort of a flurry of information which shows that there's really good engagement, but a lot of it is positive, and I think it's more of a case of they're more interested in improving it going forward rather than ever going backwards. In terms of heading back to paper, I think people would think would be a ridiculous idea, which I think is a positive.
Yeah, no, absolutely. I think if people are showing interest in how things can improve, then that's never a bad thing, is it? The trick is making sure that you've got the resource to enable that, so they don't buy out and start complaining. Some questions that have come in, and it was my fault. Apologies, you had that across the screen. I had my mouse in the wrong place. Question: how did you address the risk of unintentional errors during the first few weeks when you had fewer floor walkers? Just thinking about all these lovely workarounds that people obviously pick up, and was there any data that was captured around, you know, what you saw?
Yeah, so I think we, instead of having, so I suppose floor walker wise, we had a sort of higher level of trained super users rather than, and I suppose this is partly from my previous experiences of go lives where there's just a plethora of people on every ward. It was a bit more sort of focused. So we'd have a particular super user who literally spent, we had one super user who spent their whole shifts in cath lab, so they were just completely devoted to that area. So there was less movement rather than there being less presence. But yes, I think there probably was a reduced presence. We didn't receive any specific feedback about errors, and so I'm kind of crossing my fingers and hoping that there wasn't too many. But I expect there probably would have been that transition over to electronic and the potential for those sort of new errors. We did it, but there was a lot of work in the background to try and prevent those, particularly from pharmacy.
And another question on a very similar theme, with the fewer floor walkers that you had, did staff generally feel supported? Did you get any pushback because there were fewer bodies around, as it were?
Yeah, unusually no. And I think that was one of the things which I thought was really interesting. And I think it was a lot to do with that initial run-up, which we sort of really brought everyone on board with the idea that we were moving over to it. And I think the quality of the people who did turn up when people needed help was particularly good. I don't think I've ever been part of a go live which has had such highly skilled sort of super users, and often it would be people who were already working within the team. So one example would be we had a endoscopy nurse who'd been working, had actually retired from endoscopy, and then came back to support and be a super user for a period of 3 months. It was just invaluable because of her experience. That actually really helped. So I think that's kind of how we combated that.
And a shared purpose in the midst of a pandemic, which is always incredibly helpful.
Yes,
that
did help a lot.
Yeah, a lot done in a whole host of different ways. Another 3 questions actually, but I think summarising it, any regrets in the approach that you took in terms of Big Bang? I think that's the summary question.
I've only ever done Big Bang go lives, and I've never had any regrets about doing that, purely from an adoption perspective. But I've never been or sort of heard of a completely successful phased go live, but I think I'm completely biased on that.
Okay, we won't ask the question then, Rob. I think different circumstances and different places sometimes dictate different approaches, don't they?
Yeah. That's
fantastic. Thank you, and well done. It's obviously been a lot of work, and now you're into the fun bit, which is starting to optimize it and make sure you can do what you really want to do to make it smooth. So great. Thank you for coming back and sharing the experience. Incredibly valuable. And questions from a number of people I know who are on the journey and looking to move forward in that space. So thank you everybody for attending today. It's been a great masterclass as ever. Thank you to our 2 presenters for sharing all of their knowledge, experience and wisdom. If you have any questions, I'm sure they'd both be happy to answer any of them moving forward. The slides will be shared, as we said at the outset. Next masterclass is the 10th of November. It will be chaired by Steph Gartney, who is a clinical fellow with NHSX this year. She's going to take over the guest editor role. So if you'd like to suggest any ideas, any thoughts as to things that you might want to have covered, please do talk to her. And email Sarah, who's quietly sitting behind the scenes making all this magic happen. Thank you, Sarah. One last thing suggested today is there a hashtag for this event? So maybe we need to think about it so that we can share that it's happening. So thank you everybody. I look forward to you joining us in November. We'll either be talking about antibiotics or potentially medication safety, or even potentially controlled drug registers. We're just finalising the agenda at the moment, but there will be something for everybody and lots to learn. So thank you. Enjoy the rest of the day and see you in November. Bye for now.